So Dr. Paul Brezina is a partner and director of reproductive genetics and fertility associates of Memphis. He's a board certified reproductive endocrinology and infertility, as well as obstetrics, there we go, and gynecology by the American Board of Obstetrics and Gynecology. Dr. Brezina completed his fellowship in reproductive endocrinology and infertility at the Johns Hopkins School of Medicine in Baltimore. He earned his undergraduate degree from the University of North Carolina at Chapel Hill. He has an MD and MBA degree from the Brody School of Medicine at East Carolina University in Greenville. He also completed his residency in OB and GYN and internship in internal medicine. He currently holds academic positions at both Vanderbilt University School of Medicine and St. Jude Children's Research Hospital. His main area of research, done in conjunction with pioneers in the field at Johns Hopkins, is focused on genetic testing as it relates to IVF and recurrent pregnancy loss. Dr. Brezina has published more than 50 papers, more than 35, which were his first author, in numerous professional journals, six book chapters, and more than 50 scientific abstracts presented at national and international professional meetings. In addition, Dr. Brezina regularly gives lectures, educating other doctors on cutting-edge therapies to optimize patient outcomes with reproductive medicine. He has served as an officer on the Society of Reproductive Endocrinology Executive Board, chair of the Early Pregnancy Loss Special Interest Group within the American Society for Reproductive Medicine, board member of Advantix Genetic Testing Company, organizing committee member for the Midwest Reproductive Society International, and editorial board member of the Journal of Assisted Reproduction and Genetics. Dr. Brezina and his wife Jennifer have 2 children, and they've called Memphis home since 2012. He and his family are active involved in the community and are members of Germantown United Methodist Church. In addition, Dr. Brezina serves on the board of the Memphis Symphony Orchestra and has a passion for endeavors that promote and enhance the quality of life for people who call the Mid-South home. He and his family are also Go Grizz Nation. Dr. Brezina, I turn it over to you.
All right, thank you, Margo. I really appreciate that. And you know, you guys might have heard on the Zoom earlier. I think, but I'm gonna try to share the screen. Is that? Let's see if this is working. Okay, can you see that now?
Yep, and then start your slideshow. There you go.
I'm gonna start this slideshow. So, we've all become Zoom experts here over the last maybe 6 months or so, and it's I think an inferior thing to being able to be physically with folks. I think it's what we have right now, but you know, I think there are limitations to this format, and so I think that to try to duplicate being live as much as possible, you know, I think we've got the chat option. If people have questions during this, Margo, you can, you know, text me or do it through the little chat or whatever, and we'll try to make this as close to being here as possible, even though there's obvious limitations with this. So, you know, we've done this. I've done this talk, I think, several times here, and I haven't modified this talk a whole lot because I think that really what the purpose of this is just sort of to, you know, give people information and kind of like, I think the more times people hear sort of a framework, because there's a lot of concepts to go through, I think that helps. And then just kind of like to have a forum where you can interact in a real way. I think Margo and I were talking a little bit earlier about how for our national society, I did 4 or 5 talks yesterday, but they were just recorded with no interaction. And so I think this is really superior, where if there's something that doesn't understand, doesn't sink in, doesn't make sense, we can try to like clarify that. And so what I'd like to do is if there's parts of this talk that, hey, that didn't make sense, I'd rather go back in real time and address that and make sure that everybody's on the same page and that we have, you know, kind of everybody on board for the concepts and everything. So I'm gonna, I guess, go ahead and get started. Thank you for that introduction, Margo. All right, so yeah, she had mentioned this, that you know, I'm a partner in our practice and Advantix testing company. Okay, so I am a, yeah, I think she went through all of that. We've never actually done a HD case through our clinic. Now I've counseled people probably 4 or 5 people that had HD. Nobody has actually chosen to go through HD counseling in our clinic. We have treated a multitude of other disorders, and probably 30 or 40% of our IVF cases use some sort of genetic testing. So we have a lot of experience in that. I just not specifically in this, although the nuts and bolts of it are similar. Just to say it, I have no way of understanding what it's like to face HD. I don't pretend to. The purpose of this talk is not to say anything about what people should or shouldn't do. It's just to sort of go over the science and what's there, and just so that people are aware of what's out there. But it's not a right or wrong thing, or any sort of I have no way of knowing what people are going through, and I'm not advocating that anybody actually does or does not do anything that's going through here. Everybody's different, and I think that it's important that somebody kind of from the outside looking into this group just sort of acknowledges that, and this is just meant to be an informational thing. So I don't have to tell anybody this, but just to go through it. It's a genetic disorder, Huntington's disease is, and it's a progressive breakdown of the nerve cells in the brain. And there's, identifiable sequences that we can identify, and it gives us a reasonable prediction of how severe and disease course. But obviously with anything genetic, there's variances in how it affects different people. We call that penetrance. So I think that that we can predict to a certain degree. According to the Huntington Society Association, 30,000 symptomatic Americans are in more than 200,000 at risk for inheriting the disease. So it's not a null number. If you figure 200,000 people, that's a lot of people. Pre-implantation genetic testing. I know that everybody's heard about this. It's pretty mainstream as far as what people talk about, as far as what you hear on the news nowadays and stuff. And it's gotten more and more specific, and more kind of widespread. Like I said, I think probably 30% of our clinic uses some sort of genetic testing with IVF in general. And if you look at the national numbers on that, I know this because I just looked this up, it's about 45% of all IVF cycles in this country. Most of those are looking for splits in chromosomes that is sort of just, it's a way that chromosomes split in an abnormal way, and it's very, very, very common. And so that's what we call pre-implantation genetic screening. Another term that people are using for that now is PGTA, if you see that. And that's pre-implantation genetic testing for aneuploidy. That's distinct. So the 40% of the cycles that are going on with genetic testing, that's just looking for common mismatches in the way chromosomes split. And so a very, very, very small portion of the genetic testing, probably under 1% of that testing, is looking for very specific disorders. So things like cystic fibrosis. We have patients who, I have a patient who has, the husband has a genetic identified disorder that causes cancer. And so we are picking out embryos that don't have that. That would be an example of that. I have a patient who has a genetic hearing loss where we can identify exactly what caused the hearing loss. We're picking out embryos that don't have that. So this would be the same sort of thing where you'd say, okay, there's a sequence and we're going to make embryos and we're going to pick out the ones that don't have that. That's a different thing, because you're looking for a very specific abnormality. Typically, we do both at the same time. If we're looking for a specific abnormality, we'd also make sure that the number of chromosomes are balanced, because otherwise we'd be at much higher risk for miscarriage. So a lot of this talk is kind of going to go through what that looks like, how we do that, what that means. But this is the the general 30,000-foot view down look at genetic testing. So let's go through a review. I know I did this last time too, but just sort of how people get pregnant in general. Because I think if we don't understand how sort of the natural process works, it's kind of difficult to get an understanding of exactly how IVF works. So we're kind of gonna, I just gave you kind of like everything right at the beginning, but now we're gonna build from the ground up an understanding of exactly how that happens. So to get pregnant, you ovulate an egg and then it gets picked up by the fallopian tubes and the eggs move to about here. The sperm comes in. Only about 5% of it actually makes it past that cervical canal. And it's like kind of selecting out the strongest sperm, right? And those sperm are able to sort of smell what the egg is. They have little receptors and they can smell it and they actually go to the egg. And you might have a dozen or 100, whatever, bind to an egg, and only one's allowed in. If 2 get in, it doesn't work. The embryo then grows for about 5 days, and then it moves back down the uterus, and you have a pregnancy. So tubes are really, really important here, right? Because like they're moving everything around and they're actually growing the embryo for the first 5 days of pregnancy. So very, very important. Let's talk about normal egg recruitment. And I'm going to spend a little bit more time on the egg part of this than I am the sperm part of this, because guys are pretty simple, right? I mean, like they just sort of make sperm and then like they just kind of are always making sperm. So the egg part of this is a little bit more complicated. And so I'm going to sort of gloss over the sperm part of it because guys are simple, right? So women are born with about 2-3 million eggs, something like that. By the time you're a teenager, 90% are dead. And that's just like normal. That's just like what happens. That's not like, you know, an abnormal thing. It's just how it develops. And those 200,000 eggs that you have at puberty are kind of like everything you have for the rest of your life. And so those are like hibernating in this pool. So they're sleeping and you can't really pull them out. They're just kind of like staying there. And every month you pull out a certain number of eggs. Let's call it 20 or 30 out of that like 100,000, right? So a very, very, very small number of them. But those are activated and they can respond to hormones. The ones sleeping can't. Like you could just blast them with hormones and it wouldn't matter. The 20 or 30 that are activated though, those can respond. And I call them little gladiators. What they do is your brain tells them to fight and they fight each other and they kill each other and they have like one that wins and everybody else just dies. And that one that wins is the one that ovulates and everybody else is dead. And this every month you select these 20, 30, 10, 40, whatever it is, you select a certain number. They have the little gladiator competition and all of them will either ovulate or die. There's no like third option. Really interestingly, even if you were on like birth control pills or whatever, you were still pulling out your 20 or 30 gladiators every month. They just don't fight and they all die. So it's kind of fascinating. Women are always running through these gladiators. Even if you're shutting down the system, it doesn't shut down the selection process. And so we actually, like as an aside, we think this is like mediated actually by the spinal cord. Each egg has a little synapse right in it. So it's kind of beyond something that we can control. The number of gladiators, the number of gladiators. We can't mess with that. So what we do with IVF is right at the beginning, when you've got all these gladiators, but before they like start killing each other, we tell the brain, shut up, and we tell them all to go. So we remove this like competition thing and we tell them all to go. And you end up with as many as you can. So not all of them respond, but most of them do. So, you know, yesterday I got 30 eggs out of one woman at one time with a retrieval. So that's a lot, right? But other people might not have that many. Some might have 5 or 10 or whatever, but it's all dependent on how many eggs, how many gladiators are there each month. Cool. Does everybody kind of get that? All right, so this is just showing kind of in real life what this looks like. So that's actually an ultrasound of an ovary, and I put little little red. Is that a little question? Let me see. I'm trying to figure out how to share these questions. Okay, so the ovary, I put little red dots where the little gladiators are. You can kind of see them, those like little black things, but I put red dots. And then once we give meds, everything gets bigger, and that shows you how big that is. I mean, that ovary is like the size of a grapefruit. It's like big. Like normally the ovary is about this big. So like to go from that to that is kind of wild to me in like a matter of 10 days, you know. But that's what it looks like. And then we go in, we have an ultrasound, and it's almost I almost describe it like a video game. Like you've got this like ultrasound, but you're looking at the screen and you're just like going into these things and dodging vessels and bowel and everything else like that. So it's all done sort of under ultrasound guidance, and you can see how there's a little needle guide, and you go, this looks like it's going into the uterus, but it's not. It's actually going on like to the side. And then you go in directly into each of these little follicles, and you suck out all the fluid. And then you hope to find eggs in the fluid. So yeah, so you get this egg, and you take the sperm, and typically what we're going to do is instead of just sprinkling sperm on top, we're going to like inject the sperm into the egg. And we do that for several reasons. One, we don't want to run the risk of the egg not fertilizing. This is something called ICSI, intracytoplasmic sperm injection. But if you hear people talk about ICSI, that's what this is. And we inject the sperm directly into the egg. But for genetic testing, we think it's pretty much mandatory, because if we just throw a whole bunch of sperm all over that egg and just kind of let the best sperm win sort of thing, then that egg is coated with all this extraneous DNA from the sperm. And so you have all these other signals that give noise when you try to do a biopsy later. So typically we're going to say, if we're doing any sort of genetic testing, we're always going to do ICSI, because we can really control the amount of genetic extraneous material that's around. You make an embryo. So this never ceases to amaze me how cool this is. So this is the embryo right here in the middle. Can y'all see my cursor? Yeah, you can see me. Yeah, so that's the little embryo in the middle, and then what's around it is the placenta. And the baby will always be this, and the placenta will always be this. But they're distinct like embryologic lineages. And then we take sound and look from the top, and then show where we're putting the embryo back directly inside the uterus. Anything left over, we freeze, right? This is us doing a little biopsy, and again, like I always get excited with little videos and stuff. I think it's cool. So we'll kind of go through this, but this is, so they're taking a little laser and they're poking a hole in this little outer zona here. This is the baby part. So you see we're pretty far away from the baby part here. This is just the placental cells that are kind of trying to attach. And then we're gonna kind of grab those and pull them off. But look how much left is, I mean, there's tons of placenta left. We haven't done anything to the baby. That's kind of how we do this. And we take those cells, which are placental cells, right? They're not baby cells, they're placental cells. We take them and run them through a genetic analysis and try to figure out what they are. We assume that the placental cells match the baby cells. They don't always, but the vast majority of the time they do. This has become, you know, very, very, people, you see it all the time. Just as an aside, there are starting to be reports, actually in China, about how they're actually trying to change embryos that have already existed. That's not what we do in this country. That's considered by all of our ethical boards to be like not okay. So there is probably technology with CRISPR and stuff like that that allows actual modification of embryos, but not in this country and not at this time. even though the technology probably does exist. Anything that's done in this country is going to be just diagnosing what's already existing in the embryo kind of naturally, not modifying it. And a couple years ago, I would have told you that nobody's doing that, but that's not quite true right now. So yeah, really a great movie to watch if you have any interest in this is Gattaca. I think it was with like Ethan Hawke and Uma Thurman back like maybe, you know, I used to think it was a recent movie, but it's not. It's like 20 years old. But it kind of goes through this whole like dystopian world where, you know, embryos are modified. It's probably becoming something that's less science fiction as time goes on. Pre-implantation genetic testing has an error rate. I threw a little committee opinion that I wrote over on the side. This was published in our journal, so it's endorsed by kind of everybody. But we're going to tell people that the chance of PGS being wrong or any sort of genetic testing being wrong is this 5–10%. It's because when we take that biopsy from that placenta, remember how I showed you that the placenta was kind of a different part than like the baby itself? And the placenta could be a little different than the baby. Now, 95% of the time, it's the same, but it's not always the same, which means that this testing is not perfect. I want to talk about aneuploidy a little bit. And aneuploidy sounds like it's a really fancy word, but that's what we call it. So remember when I said earlier, like maybe 40%, 50% of cycles in this country were genetic testing? This is what they're looking for. They're not looking for any sort of like particular genetic trait. They're just wanting to make sure that the embryo has 23 pairs of chromosomes. You know? So everybody's heard of chromosomes, right? DNA, packaging chromosomes, all our cells have chromosomes. So everybody has 23 pairs of chromosomes. It's like, you've heard of that genetic testing, like 23andMe, that sort of thing. I secretly think that's why Michael Jordan chose 23 for his jersey. Like, just like it's a really important number for like human reproduction. So you have the chromosomes, and they're pairs, right? So they're together. And whenever you make a cell, like a cheek cell or skin cell or whatever cell you make a copy, but they kind of stay together and then they peel apart. But the other ones like stay over there. So when you make an egg or a sperm, though, you're not making a whole U. You're making a half U. And when you make a half U, you split those apart. And this one becomes an egg, and this one becomes an egg. You throw this one away, and you're left with this as the egg. But they have to split. If they don't split, it doesn't work. So if they don't split, then you have them stay together, and you have an egg that either has two or none, but it doesn't have one like it's supposed to, and then you end up with 3 or 1 copies, and that doesn't work, and that miscarries. This is like uber common. So you see that like even when people are in the 30 age range or so, 25 would be the same thing, you still got this aneuploidy rate of like 30%. And so like even in young folks, your miscarriage rate is going to be about like 25–30% simply because of this. And that's just because 25–30% of them are going to be abnormal. So if you think about it, like if you talk to people in your family or your church or whatever, I bet a lot of money that people that have 3 or 4 kids on average have had at least 1 miscarriage. And if you think about it like through your family, that math probably plays out to be like something that's about normal. So like for every 2 to 3 kids, you'd expect 1 miscarriage. And that's probably about what you would see in your family, I would bet, or your friends or church or whatever. We think that this is the vast majority of first trimester miscarriages. I put 50 to 70%. Honestly, that's a pretty conservative number. A lot of people would say 80 or 90%. Okay, so what we do with IVF is, well, you figure you gotta have 2 to 3 eggs to get a good embryo, or to get an embryo that looks good. And then of those, the chances of having at least one with an abnormality with the number of the of the splits, right, is going to be 30% in young people, but in somebody that's 40, that number might be 80 or 90. I mean, it's like really high. So the idea is that if you can get enough eggs, you can maybe overcome that math, right? So like the person yesterday with 30 eggs, well, we can overcome that math, right? Because what we can do is we can say, okay, well, we're going to end up with 10 embryos. And then let's say that half of them are abnormal. Well, that's okay because I still have 5 normals left. And what I'm doing with this testing is I'm avoiding like miscarriage with this, miscarriage with this, miscarriage with this, right? So it's just a way to make things more efficient. The same number of people would have gotten pregnant at the end because you would have transferred all of these and the good ones would have eventually worked. It just would have been a little bit less efficient. The older people get, the more this helps because the higher percentage of the ones that are abnormal. The younger people are, the less it matters because if you're only 20 or 30% abnormal to begin with, you know, you got a pretty good chance of picking a good one, just pot luck, right? So let's talk about this PGD for HD. What we would do is basically that same thing. We would just superimpose testing for HD on top of it. So it's kind of like each embryo would undergo 2 tests. One would look for the number of chromosomes, and another test would look for HD. And then you would get a number that looks something like this. I mean, it was just a guess, and I tried to be random in putting these together, right? So, like, yeah, so this is not affected, and it's normal. That's when we would use. But this one is normal for the number of chromosomes, but it's HD, so we wouldn't use that one. This one, the same thing. This one's normal for HD, but an abnormal number of chromosomes. They got to be good for both. So instead of having 4 or 5, it cuts it in half, kind of, right? Because it's autosomal dominant. So half of, so half the normal ones are going to have HD, and we can't use those. And once you know that something is HD, you can't ever transfer it. Nobody will ever transfer it. So you could go to any clinic in the country and nobody's going to take, I mean, nobody's going to transfer it. So it becomes a little bit ethically thorny too with what do you do with these embryos? Like, what do you do with this one that could result in a live birth, but is HD? Now, this one over here, it would be a miscarriage and it's HD. I think most people could feel pretty ethically okay with maybe not, you know, letting that one go. But I think that these over here become tougher. And so I just like to acknowledge that, right? But we nor anybody in our field would ever transfer these, frankly, for liability reasons, if nothing else. So the ones that are normal, you'd transfer. Now, you know, the error rate is going to persist at 5–10%. You never get around that. So it could be that I'm wrong and like this one actually is abnormal or actually has HD. So the only way that you're going to actually get rid of that risk completely is to use either donor eggs or donor sperm, because you're always going to have this background rate where I can be wrong. I acknowledge that. Like, so the only way to completely sidestep it is just to not use that genetic material to begin with. This is just going over that increased rate of aneuploidy with maternal age and the chance of miscarriage with it. So, you know, it's not a coincidence that the chance of miscarriage, you know, goes up as the chance of pregnancy goes down. We talked about egg quality. I think I spent a little bit of time talking about that with the way the chromosomes split and stuff. And the egg quantity, the number of eggs, the number of gladiators is also going to go down as time goes on. So in addition to there being a higher and higher percentage of eggs that won't work, in addition to that, I have fewer and fewer eggs to deal with. And that's why the chances of IVF working drop off so significantly from 35 to 40. Take HD out of it. If I take 2 embryos that are not genetically tested at the age of 30 and put them back inside a uterus, somebody that's 30, I'll have about a 55% delivery rate. I do that at 35, it's about 50%. If I do that at 40, it's 10, which is kind of striking to me, right? So now it's all about the egg. I could take somebody that's 45 or 48, and if I get a donor egg from somebody that's 23, their chance per transfer with a single embryo is 60%, which proves the point almost undeniably that it's all about the egg. It's not about the uterus, it's not about the sperm, and the guys are still 50, right? But if I get a donor egg, we'll have a 60% pregnancy rate with somebody that's 45. So it's really all about the egg and what I do. For that, you have this option of kind of like oocyte cryopreservation, where you can, freeze the eggs when you're younger, and the idea is that you can use them later. I'm seeing this more and more. I had a patient that I saw yesterday who came in for the first time and said, "Hey, I'm I'm a young physician, and we're just not ready to have kids now, but I'm 33. I want to freeze my eggs." And then she's already married. She's like, "My husband and I will use them later if we want to." I was like, okay. So that was like completely, that was just her idea to come in and get her eggs frozen. And so we're seeing that like just more and more and more just in the general population. She didn't have any particular thing that she, was worried about. She just wanted this sort of insurance policy. And they had never tried to get pregnant. Limitations of PGT and PGS, 5 to 10% error rate. I've tried to kind of cover that and why that's important. Cost is a major barrier. Egg cryopreservation just by itself is probably about 10 grand. IVF with genetic testing is 12 to 15 grand. PGS adds 3 to 5. The specific genetic disorders are harder because they've got to sequence out the specific sequence for each patient. So they have to go through, figure out the sequence, and then like make a probe for that specific sequence. We don't do that. We send that to Chicago. There's only a couple labs around the country that handle that. So decision what to do with HD embryos, I think I talked about that earlier. I'm not making I have no idea what the right answer is with that. I can just tell you from, if nothing else, from a medical legal point of view, nobody's going to ever transfer those embryos. Interestingly, the way our system works, the kid, so the parents can't sign away risks for the kid. So you can sign away risks for yourself, but you can't sign away risks for other people. So there's no way that a couple could sign away risks for their kid, and the kid could theoretically come back later and say, "Hey, you gave me this." So because of that, no clinic is ever going to touch it, because no matter who comes up with whatever contract, there's no way for individuals to sign away risks for the kids that can result from that. So in conclusion, HD is a devastating disease. PGD, PGS may be used to greatly reduce but not eliminate the chances of having a child affected with HD. It's not universally successful, and in fact, the chances of IVF working with genetic testing for any couple undergoing PGT for this would be half of what it would be in an age match control, or half of what it would have been without HD. Because if you think about it, HD is knocking out half the normal embryos that I could have used. So it by definition cuts IVF success rate in half. Whatever the success rate was, it's half with HD. It's not perfect. It has a lot of challenges, and I'm not saying that it's a right or wrong thing or whatever. I'm just saying it's just what's there. Yeah, and just we're always trying to be the the best resource we can for the community. Publish a lot, talk a lot, probably talk too much.